Good evening. On behalf of Jagsonpal Pharmaceuticals Limited, we welcome you to the Scientific Sangam 37. This web series is organized by ISOPARB Prayagraj in association with Allahabad and Kanpur Obs-Gynae Society and the ISOPARB Burla Sambalpur chapter. This webinar has been assigned 3 ICOG points. We welcome you all to the webinar. The academic partner is Jagsonpal Pharmaceuticals, makers of FE protein, the newly launched product. We welcome the organizing chairperson, Dr. Ranjana Khanna ma'am. Dr. Ranjana Khanna is the National Vice President FOGSI 2017. She is the founder president of ISOPARB Prayagraj 21-25. And we have been doing so many scientific sangams with her. Thank you so very much, ma'am. And she's the ICOG Governing Council member 21 till 25. We hand over to you, ma'am.
A very good evening, everyone. At the outset, a big welcome to everyone who has come for this webinar. First of all, before we start anything, I fold my hands in prayer to Lord Shiva. Today we are going to have very interesting topics, and at the outset I want to welcome the chief guest of the program, Dr. Meera Agnihotri ma'am. It gives me immense pleasure to introduce and welcome my teacher, my friend, my mentor and my guide. My love for obstetrics stems from her teachings. She taught me all the nuances of obstetrics, and I'm always grateful to you and will always remain grateful to you, ma'am. Thank you so much for all the love, all your teachings, always. So, Dr. Meera Agnihotri, we all know, has been professor and head of Gynae GSVM Medical College, Kanpur, and chairman, ethics and research, State Medical College.
Ranjana, we should not waste time.
अरे पर आपके बारे में बताने तो दीजिए.
कुछ भी. We love you.
This is utilization of time.
It is just we convey my love to everybody and start.
President WWW Foundation and successfully led collaborative group of 13 organizations supporting FOGSI position statement to Ministry of Health, Government of India for COVID vaccination to lactating and pregnant women. And she has got lots of awards to her credit, lots of commemorations, and she's got a Lifetime Achievement Award, FOGSI. And I remember she got the Lifetime Achievement Award in ICOG also. That was the time when I became FICOG. And madam, we welcome you very warmly, and I welcome you from the bottom of my heart to give your blessings. And as you know, Kanpur is very, very dear to me, and she is from my hometown. And very, very warm welcome to all my friends from Kanpur. And of course, from Burla. Burla holds a special place in my heart. And the girls who are here, they have been extremely nice to me, and they are my good friends, Ojaswini and Leena, who are here.
Thank you, madam.
So welcome all, and ma'am, please, I wanted you to speak a few words to bless us.
At the outset, I extend my love and my gratitude, heartfelt gratitude to one and all, including Dr. Ranjana Khanna, first of all, for making me to sit over there in spite of everybody telling कितने दिन तक आप पढ़ती रहेंगी, but I said नहीं, हमें अभी पढ़ना है. And my friend Dr. Manju Varma, who is the expert in this thing, she is being appointed as expert. So need not to worry. Everything will be expertized as soon as the lectures are over. So Manju, I am very happy that you are there. So you can pick Manju or Meera. So it's equal.
ऐसा नहीं
So,
मीरा जी, आप
Manju,
हैं, मैं
Manju, thank you very much for being here. Then speakers, our committee chairperson from Kanpur, Kiran, and Kanchan, NCD committee ki chairman and medical education committee ki chairman, and learned speakers include none other than Ranjana. इतना clarify हो जाएगा, crystal clear आपको whatever you are going to learn. After leaving this webinar, you will yourself become a teacher and finish it up. Ojaswini is a wonderful speaker. She is very good. And Amita Tripathi, very close to my heart. She is very well prepared in all the subjects. And another Shubha. Am I right?
Kiran ma'am.
Shubha is another speaker. So all
Kiran
the
Dr. Kiran
speakers
Pandey.
are really wonderful. And I believe that you will be going back with so many back home lovely messages, although you know them very well. Then first session chairperson, Dr. Tripathi, Dr. Chitra, and along with Kiran, you have got Leena, you have got Shelly. ये सब मजे हुए कलाकार हैं, इनसे कुछ कहने की जरूरत नहीं. They are all well trained, and Amita will be chaired by Suman and Abhilasha. I know their caliber so very well. And Shubha, thank you very much for everybody being present. I am feeling honored to be surrounded by two chairpersons and one great dignitary of the national level, Ranjana, governing council member, and reaching to the a little high, one of the highest places from Uttar Pradesh in our FOGSI. And I personally feel आप लोग जितने भी लोग हैं, सब लोग गो हेड, और आगे बढ़ो. हमारे दोनों चेयरपर्सन अगले वीपी के लिए बी प्रिपेयर्ड. एंड Amita and everybody, they are so talented, so well prepared. I know, and I've learned them, I've seen them talking so much. आज के सब्जेक्ट्स बहुत अच्छे आपने चुने हैं, लेकिन खाली उसको एनसीडी का करके मत याद करो. You have to prepare these subjects very well. And all of you are fully aware that हमारे प्रधानमंत्री जी और हमारे उत्तर प्रदेश के जो मुख्यमंत्री हैं, उनकी अति महत्वाकांक्षी योजनाओं में एनसीडी is one of them, which includes anemia मुक्त भारत, and this पोषण युक्त भारत, कैंसर मुक्त भारत. So the subject chosen by Ranjana, as it was very well expected, कि she will be coming with all these things. तो आज बहुत अच्छा होने जा रहा है, मुझे मालूम है. It will be a wonderful session. और साइंटिफिक कमेंटेटर नन अदर देन मंजू, जिन्होंने एक छत्र एकेडमिक राज्य कराया इलाहाबाद में और हम सबके दिलों पर. I'm fully prepared that we will enjoy it. I always enjoy your company, and I will be here so long I am there. I will be very happy. So Ranjana, don't waste time. और सबका ज्यादा इंट्रोडक्शन मत दो. We are all a family member. And every family member knows that I am their family member. So that's all. No other introduction but a family member.
But it is my privilege to have two chairpersons of FOGSI today in our webinar. I want to acknowledge Dr. Kanchan Sharma, who is chairperson of the NCD committee of FOGSI, and Dr. Kiran Pandey, who is chairperson of the medical education committee. So welcome everyone. And I never forget to acknowledge my senior, my elder sister, Dr. Manju Varma, who always stands by me through thick and thin. So welcome all. And now I hand over the session to Dr. Amita Tripathi.
Thank you, Ranjana ma'am.
Madam, wonderful words. Thank you.
Thank you. A very warm welcome to all the faculty and delegates, and pranam to Meera ma'am and Manju ma'am. Thank you, Burla ISOPARB, Kanpur Society and Allahabad Society for holding our hands. And so without wasting any time, we would like to start with the first session, which is about the pathophysiology and management of Rh negative pregnancy, which will be covered by our own founder, president of ISOPARB Prayagraj, Khanna ma'am. And to chair the session, we have two very active members from Kanpur Society, Dr. Kanchan Sharma ma'am, who is very apt for this today's webinar that is on NCDs. She is National Chairperson of Non-Communicable Disease Committee, FOGSI, and she is Director and Senior Consultant, Akash IVF Kanpur. She has organized various conferences. Recently, she has organized NCD conference also, and she has published books on NCD updates, and chief editor through FOGSI, author and chief editor of High Risk Pregnancy FOGSI Focus. And she has received various awards like FOGSI Achiever Award, FOGSI UNICEF Appreciation Award. Welcome, Kanchan ma'am.
Thank you.
And our next chairperson is Dr. Reshma Nigam. She has a very dear, she's a very dear friend. She was alumni from our MLN Medical College. And please change the slide. Right now, she is secretary of Kanpur Obstetrics and Gynecological Society. She has more than 30 years of experience with special training in ART and IVF, with vast academic experience in every Kanpur conferences. We have seen her in the organizing committee, and she has been treasurer, scientific secretary of KOGS. Welcome, Reshma. And with this, I request Dr. Reshma Nigam to kindly introduce the speaker for today's topic, Dr. Ranjana ma'am.
Thank you so much, Amita Didi. My sincere regards to my teacher and mentors, Dr. Meera Agnihotri ma'am, Dr. Manju Varma ma'am, Dr. Khanna ma'am, Dr. Kiran Pandey ma'am, and all the chairpersons and all the speakers. The first, without wasting time, I am going to introduce the first session. That is, topic is overview and pathophysiology of Rh isoimmunization. That will be covered by Dr. Khanna ma'am, and her introduction is I think Dr. Meera ma'am ने तो already इतना अच्छे से introduce कर दिया है, but for this she has been National Vice President FOGSI 2017, ICOG Governing Council Member 2021 to 25, Founder President ISOPARB Prayagraj Society 2021 to 25, President Allahabad Gynae Society 2013 to 17. She has been organizing secretary for many national conferences, and she delivered so many orations as well as lectures in many national conferences. And she has been author of many articles in various books and the journals of FOGSI. Welcome, Dr. Ranjana.
Thank you so much, Reshma. Thank you so much for the lovely introduction.
Every word is less for you in your appraisal. We all are very fond of you. We always know because of your quality only, madam.
With your talk, ma'am.
So, very good evening. Today, I am going to speak on a subject which you all have heard off and on, but I am sure you will get a few take-home points which you never noticed. So, Rh factor came into existence by Philip Levine in 39, Landsteiner in 40, anti-D prophylaxis by Freda and Gorman in 1960, and the pioneering achievement in the intrauterine transfusion and Lilly's chart was introduced by Sir William Lilly in 63. First direct intravascular transfusions by Charles Roddick. So what is the basis? Now the overview, I'll tell you. There is an Rh negative mother. There is an Rh positive baby. The blood streams of the two are separated by a placenta. When there's a slight breach in the placental barrier, then these Rh positive cells can go into the maternal circulation. So normally in the antenatal period, except for a few sensitizing events, these cells, very few cells go into the maternal circulation. But what happens when this child is delivered and the placenta comes out, then fetal blood goes into the maternal circulations. These Rh positive cells will motivate the immune system of the mother to form antibodies. IgG antibodies are formed against these Rh positive cells of the fetus. So now if anti-D is given, these cells are destroyed. Suppose anti-D is not given. These antibodies take 6 weeks to 6 months to form. And once these antibodies are formed, the mother gets sensitized. And sensitization is for life. Once she has these antibodies remain in her bloodstream for life. So whenever she next conceives a Rh positive baby, these antibodies will enter into the fetal circulation and they are now going to destroy the fetal cells, leading to anemia, hemolysis, jaundice, eye drops, and even fetal death. So now this is the basis what we are going to talk about. So what are the conditions in which little amount of a breach takes place and these fetal cells can enter into the maternal circulation in the antenatal period? Threatened miscarriage, ectopic, molar, antepartum hemorrhage, amniocentesis, chorionic villus sampling, chordocentesis, external cephalic version, abdominal trauma, IUFD, and of course delivery, we've talked about that. Now silent FMH. Silent FMH refers to antenatal or postpartum entrance of the fetal blood into the maternal circulation because of failure of the placental barrier. The clinical consequences range from non-significant to catastrophic neonatal outcomes and are dependent upon the volume of the fetal blood loss and whether it was acute or chronic. So normally it is less than 1 ml and so it is not so significant. So now there are 2 types of FMH. It could be unimportant when in less than 0.5 ml is there in 96% of women and less than 15 ml even after delivery in 99% of women. What is clinically important or massive FMH? There is no universally acceptable definition of massive FMH. Some say it is 30 ml. But 30 ml is the amount that is neutralized by the 300 micrograms of anti-D that we give postpartum to the mother if she delivers a positive baby. So this is given within 72 hours and this 30 ml is easily neutralized. Some say it is 80 to 150 ml. So what becomes important is to ascertain, to quantify the amount of feto-maternal hemorrhage that has actually taken place. Because we are only giving 300 micrograms, that is going to neutralize only 30 ml. For every 1 ml more of fetal blood entering into the maternal circulation, 10 micrograms more of anti-D is needed to neutralize that. So we must remember that it is very important when we are expecting a massive FMH to please quantify. And if you are in doubt and if there is no means to quantify, give 2 vials instead of 1 vial. That will certainly help the patient. So it could be acute or chronic. And what are the causes of feto-maternal hemorrhage? Be maternal abdominal trauma, placental abnormalities, then maternal causes like hypertension and substance abuse, obstetrical procedure-related causes, amniocentesis, chordocentesis, external cephalic version. So what is the pathophysiology of FMH? The pathogenesis is unclear. Normal placental connections in the trophoblastic layer allows minute bidirectional blood flow between the mother and the fetus. Breach in the placental trophoblastic layer barrier can occur and the fetal blood cells move away from the higher pressure fetal circulation into the lower pressure intervillous space and ultimately into the maternal circulation, causing temporary maternal chimerism. So what are the reasons? Intervillous thrombosis, villus edema, some problems with the placenta, retroplacental hemorrhage. Then see, this Rh positive baby is in the Rh negative mother. And as I have said, there's these cells, if they go into the maternal circulation, if they are not destroyed, then what happens that they give rise to IgG antibodies are formed against the Rh positive cells. and the mother gets sensitized. And it takes 6 weeks to 6 months. And so normally the first baby escapes, but it is from the second baby onwards that the problem starts if we have not destroyed these fetal cells which have entered into the maternal circulation. So anti-D antibodies remain in maternal circulation throughout life and the patient is sensitized. Once sensitization has occurred, it is irreversible. However, it does not adversely affect the health of the mother. So when the patient first comes to us, we do an indirect Coombs test. Is she sensitized? Is she not sensitized? If it is negative, again repeat it at 28 weeks. If it is again negative, then go in and give her an anti-D, a shot of anti-D for all the sensitizing events that can take place in the antenatal period. Initially, it was said 100 micrograms at 28 weeks, 100 micrograms at 34 weeks. But now the dictum is very clear. We have to give 300 micrograms, 28 weeks, preferably 28 to 30 weeks, but maximum up to 34 weeks it can be given. So there's what happens in the ISO-immunized subsequent pregnancy. We talked about this. IgG antibodies goes from the mother to the fetus. Antibodies attack the Rh positive cells, anemia, hemolysis, eye drops, all these cases take place. Now, fetal RBCs cross the placenta in 5% cases in the first trimester, 46% in the third trimester, 100% during parturition. Now, we have seen that though mixing takes place, but why is it that some mothers are more sensitized than the others? See, what happens is that we must remember that for isoimmunization, there is a lower risk if there is ABO incompatibility between the mother and the fetus. So why does it happen that way? Because these fetal cells, if they are ABO incompatible with the mother also, if they enter into the maternal circulation, because of the ABO incompatibility, first they are destroyed. So the Rh antigen does not get exposed to the maternal immune system. So there are less chances of Rh isoimmunization if the mother and the fetus are ABO incompatible also. Sensitization depends on the volume of blood entering into the maternal circulation, mother's immune response, and there are many people who are non-responders. So, Freda and Gorman in 1966 introduced the anti-D prophylaxis. So, he said that overall risk of isoimmunization of the Rh negative mother with the Rh positive fetus was 16% only. The risk reduces after postpartum administration of anti-D to 1%. And if there is antepartum administration also, then it is only 0.1%. So this was a major medical achievement in preventive obstetrics. We all know that we have to give anti-D, and this anti-D will, the Rh positive fetal RBCs that enter the maternal circulation are destroyed by anti-D. Thus, the D antigen in the fetal RBC is not allowed to be presented to the maternal immune system. So prophylactic antenatal anti-D is recommended at 28 to 30 weeks following an episode of antepartum hemorrhage, spontaneous or threatened abortion, external cephalic version, blunt trauma to the abdomen, post-amniocentesis, chordocentesis, post-delivery. If there is intrauterine fetal demise, maybe because placenta has separated, there's a retroplacental hemorrhage. In these cases, it is very essential to do a quantification of the feto-maternal hemorrhage that has taken place. Because unless you quantify, you'll end up giving a lesser dose than is required, causing sensitization to the next baby that comes in her womb, which is Rh positive. So careful history is very important. Ask the mother, has she had an abortion, maybe an MTP, was she given anti-D, whether she has received any blood transfusions, check husband's blood group and Rh factor. Rh negative mother with Rh positive husband, indirect Coombs test at booking, and then 28 weeks, if negative, give anti-D and no further testing is then needed. These monoclonal anti-D antibodies have been introduced, which are actually free from all risks. Now, what are the precautions you take at delivery? No methogen after delivery. No IV methogen. Actually, the patient is bleeding a lot. You can give intramuscularly methogen. You don't want the uterus to squeeze tightly, because if it squeezes tightly, lot more fetal blood cells will enter into the maternal circulation. No manual removal of placenta. Cord blood sample is collected for hemoglobin, direct Coombs test, blood group, serum bilirubin. Anti-D is given within 72 hours of delivery if the neonate is Rh positive. And of course, we must remember one basic thing, that this anti-D should be given intramuscularly in the deltoid muscle, preferably, or anterolateral aspect of the thigh. Why not the gluteal muscles? Because there'll be erratic absorption because of the fat in the gluteal muscles. So, of course, there is some benefit even if you give within 28 days of delivery. Now, 1 in 1,000 deliveries result in large FMH. Which are these cases in which large FMH is expected? Intrauterine fetal demise, bleeding placenta previa, abruption, and manual removal of placenta. So in these, it is very essential that a Clearhead-Betke test is done to quantify the amount of feto-maternal hemorrhage, and then we calculate the dose of anti-D to be given and do accordingly. So this is the KB testing. Now, what about those who are weakly positive, weakly negative? A woman whose blood was typed as weak D, categorized as Rhd negative for transfusion. And if pregnant, they have to be given anti-D. But weak D, if detected in a donor, is taken as Rh positive. So we all must know that there are sensitizing events in the early trimester. We have talked about abortion, though there are many schools of thought. RCOG is very conservative in giving anti-D. So they say if it is a spontaneous abortion less than 12 weeks, it's better not to give. You don't have to give. There's not mixing. But if, of course, you have done an evacuation, then you have to give. But then they only say 50 to 100. And they always want to quantify. In each delivery in Britain, they quantify the amount of fetal blood cells that have entered into the maternal circulation, and only then they will give the anti-D. So what are the ICOG FOGSI points to be considered? First trimester, we have talked about these cases. So 50 to 100 micrograms, which is not available in the Indian market. So we end up giving 150. So remember, it's always better we can give an overdose rather than give an underdose. Second trimester, and then we will see at 28 weeks, 100 micrograms initially it was said, now we give 300 micrograms. And of course, in the third trimester, if there are sensitizing events like amniocentesis, we are doing abruptio placenta, blunt trauma, then in these cases also we recommend 300 micrograms. So now, what are the things which are yet to be done in India? An Indian survey suggests that only 10 to 20% doctors prescribe prophylaxis after MTP, miscarriage or ectopic. So please, awareness is the key to success. We must make the health workers aware that even in cases of an MTP, we must find out the blood group of the patient. And if she is negative, give a dose of anti-D. And even though standard dose of 300 micrograms covers maximum cases, determination of size of FMH is recommended. We should counsel all the girls. Instead of gluteal muscles, this we've talked about. And all non-sensitized women should be given prophylaxis to avoid risk of sensitization. Efforts on improving FMH testing should be done. And now molar pregnancy, it's very doubtful. Some say if it's a complete mole, don't give. But for that, it has to be decided very carefully whether it was partial or whether it was complete. So the dictum is to give rather than not give. So now one thing very important I wanted to point out was that the median half-life of anti-D is 23 days in the third trimester. So if you have done external cephalic version, Within 21 days, the patient now delivers. And or if you have done amniocentesis and she delivers within 21 days and she gives birth to a Rh positive fetus, do you have to repeat the dose of 300 micrograms? No. If within 3 weeks she has delivered, given birth to Rh positive, don't repeat. You have already given the 300 micrograms of anti-D and the median half-life is 23 days. So we must remember this. Now, suppose the patient is ICT positive. Now we will see the Rh antibody titers. Once indirect Coombs test comes positive on initial screening, monitored by Rh antibody titers 4 weekly. Titers continue to remain below the critical level. Then you deliver at term. Now, what is the critical level? Some labs have different levels, but normally it is 1:8 to 1:32. But we take normally the cutoff as 1:16. So this is the critical level below which the baby remains unharmed. And in these cases, no need for anti-D prophylaxis. So critical titers, no need for, okay, we've talked about this. Now what happens? Critical titers have been crossed. Then we will now depend upon, no need to do the titers further. We will now depend on the ultrasound to guide us. And we will see the MCA PSV, if it's more than 1.5 mom intrauterine transfusion. So nowadays, lots of these babies are saved because of this intrauterine transfusions. FOGSI guidelines. All Rh negative women should have an ICT, okay, and then again at 28 weeks. Now, in case if the woman has had anti-D prophylaxis, either following a sensitizing event maybe, no need to do ICT because that is going to come positive. So we will get confused further. So at the time of delivery of Rh negative mother, documentation of blood group and status of the neonate is a must. So this we've talked about. And we all know that FOGSI now recommends routine antenatal anti-D prophylaxis known as RAADP. Rh negative women may have silent bleeds, so 300 milligrams intramuscularly in the deltoid is effective, economical, offers better compliance. Now to conclude, most of the FMH cases remain asymptomatic and underreported. Mild FMH is seen in almost 95% pregnancies. And what is very important is the quantification of the FMH. So whenever you are in doubt, please try to get it quantified. If you can't, it is better to give an overdose of anti-D rather than to give an underdose. And more research is needed to develop new interventions, improve on existing interventions, and to ensure that the existing technologies as well as those to be developed are equitably distributed to reduce this burden of feto-maternal hemorrhage. Thank you so much.
Thank you, ma'am. This was really a wonderful webinar, I can say. And because this is a very important condition which we can say, because fetal isoimmunization, because of Rh negative mother and Rh positive fetus, that happens many often. And as you said, that depends on the feto-maternal hemorrhage. And we should quantify it, whether this is a slight or this is a more. If it is less, then of course 300 micrograms should be given, and overdose is to be given. That is always appreciated rather than underdose. And I like your point that we should train our paramedical staff that they should give this injection in the deltoid region rather than the gluteal region, because as the things you have told, because of the more of the fat and many other things. And other thing is indirect Coombs test. The more we should be concerned about the second time when the patient becomes pregnant, there are anti-D because of the feto-maternal bleed, and she has not taken any anti-D. And in that very case, if we do indirect Coombs test, that is very important. First, if in case this comes to be negative, then even we have to repeat at 28 weeks. This is very important just to reduce the further fetal demise incidents. So thank you very much. You have very well explained all the points. And
I wanted to welcome you, Dr. Tripathi. Thank you for joining. It's such a pleasure to see you all after that lovely trip
my
to
regards to
Sambalpur.
Dr. Manju Varma, Dr. Meera Agnihotri madam, and Dr. Kiran Pandey madam. She has joined, and Dr. Tripathi sir, and everyone.
Thank you so
Thank
much,
you,
ma'am.
madam.
Wonderful
Dr.
talk.
Kiran, we were remembering you a lot, but you were not, you hadn't joined then.
Actually, I was driving, so I had kept it and totally.
Ah.
I mean, I just now, you can say, dropped into my house and on the laptop.
Meera ji, do you have to give any comments? Is ma'am there?
मंजू मैम तो है,
नहीं, मीरा जी भी हैं।
मैम
मीरा
मैम
जी
भी
भी
है।
हैं, मीरा जी
हाँ, है।
अनम्यूट, हाँ।
हाँ,
मैम, अगर
Unmute
आपको
करिए,
याद होगा,
unmute.
मैडम, अगर आपको याद होगा, the first talk I gave in GSVM, when we formed a small group, you were the president, I was the secretary.
I know.
And then the first talk I gave was RH,
I know.
ISOIMMUNISATION.
क्या
We
बात है।
invited all the private practitioners also. And Dr. Rohatgi said, you have spoken so well, so kal
Well.
tumhari chutti. So she gave me leave for one day.
अच्छा, ऐसा भी होता था। मैडम, अब कब होगा ये छुट्टी मिल जाए?
He said कि रंजना तुम इतना अच्छा बोली हो कि बेटा कल तुम ऑफ ले सकती हो।
अब
अरे
मैडम
वाह।
कहेगी तुम लोग अच्छा बोलते ही नहीं हो, इसलिए अब तुम्हें दे
अरे वाह।
देंगे।
नहीं, बहुत बढ़िया, इट वाज ए वंडरफुल प्रेजेंटेशन।
Thank you so much, madam.
अंडर ग्रेजुएट, पोस्ट ग्रेजुएट, डीएनबी, पीएचडी सबकी समझ में बहुत अच्छा आ जाएगा। एंड गाइडलाइंस जो इसमें ऐड करी, आई एम वेरी फॉन्ड ऑफ एडिंग गाइडलाइंस एंड recent advances in every subject because there are revolutionary changes going on.
हाँ जी।
पहले 300 माइक्रोग्राम के लिए इंजेक्शंस के लिए कहा था कि अबॉर्शन के बाद देना है कि नहीं देना है, एंड सो ऑन. तो these things were very very clear. And about the mole which you have talked about, तब तो journals में भी आ गया है, everybody is discussing about it. So it was a very good presentation all through. सारे points ये note करने वाले हैं. और एक चीज जो बहुत बहुमूल्यता से सबसे पूछी जा रही है कि that I have got a RH negative mother, उसके 6 बच्चे हो गए हैं और उसमें से 2-3 पॉजिटिव भी हैं और निगेटिव भी हैं, बट नथिंग इज हैपनिंग, ना किसी को जॉन्डिस है ना कुछ।
I explained that, madam, कि
you see, yes, repeat it again because
हाँ.
that is very very important.
Because अगर ABO incompatibility होती है, chances of RH isoimmunization is much less. And
Right.
sometimes the mother just does not get, her immune system is not so good as to form the antibodies.
Right.
So in that case also.
This is the latest concept which has come into picture, that if your patient is RH negative and husband is RH positive, so there is no 2 2s are 4, 2 3s are 6. It varies from patient to patient.
Yes.
And it also depends upon the immunity response. My
Bilkul.
immunity response may be different, yours may be different. And if 10 persons are sitting there, may be different. So they have produced that girl who was having so many children. Kisi ko na jaundice, na kuch, and this mother is RH negative. So for those especially who are preparing for DNB and PhD, I think these are the things which are still to be discussed. And they are also trying to come up with the immunity parameters, which are not still skilled. So wonderful. Keep on clapping for a wonderful presentation.
Thank you, madam. मंजू दीदी, आप कुछ बोलोगे?
अरे मैं तो भूल गई थी, मुझे बोलना ही नहीं था, मंजू को ही बोलना था।
हाँ जी।
सब बोल चुके हो. Again, a congratulations for such an elaborate, clear
Good evening, Dr. Manju.
presentation that you have done. But one thing I would like to add only here is if the mother is RH negative, please do the RH of the husband also.
Yes.
The first investigation that has to be done. And बाकी आप सब बता चुके हो. I don't think I need to comment anything now.
Dr. Tripathi, you want to say something?
बोल दिया.
Dr. Tripathi, you want to say something? Ma'am, Dr. Tripathi is a very senior gynecologist of Sambalpur.
Right.
Ma'am, that you have recognized it. So my only request and my only suggestion and the only suggestion is to make aware our doctors.
Yes.
do the test. Because as you have already described, you have already explained that doing the test in ectopics or even many patients, they come taking the abortion pill themselves. They come for a checkup and they come for a consultation. We must do their groups and RH even, if you go RH. So without explaining the doctor, without consulting the doctors, many times they themselves so much to take the abortion pills. In those also, we must be very aware. The next time I'm going to conceive, we must know their RH status, both wife and husband.
Yes. That is why
unmarried
history is very important.
Madam, the unmarried,
Any role of NIPT?
madam, the unmarried girls, they are coming now. Many unmarried girls, they take on this abortion pill and they come for checkup. We must do their RH status immediately and there, even if she is not married. So that's my message and my suggestion.
Chalo, Amita, let's move on to the next.
Thank you, Ranjana ma'am. It was a wonderful talk with very crystal clear messages. So moving towards the next session, very interesting topic, managing sickle cell anemia in pregnancy, will be taken by none other than President of Burla OBGYN Society, Dr. Jaiswal Patel. And to chair the session, we have with us Dr. PL Tripathi. अभी हम लोग इंट्रोडक्शन हुआ सर से. Sir is Director, Kishori Hospital and IVF Odisha. He is trained in infertility, laparoscopic surgery, maternal and child health from Liverpool, UK. He is presently working as Director and Chief Fertility Consultant at Kishori Hospital and IVF. He has conducted more than 17,000 vaginectomy and more than 1,700 take-home IVF baby delivered from Kishori IVF. Welcome, sir. And our next chairperson is very dear friend and Dr. Chitra Pandey. She is Director and Consultant OBGYN at Harsh Hospital, Allahabad. She is a fellow of ICOG. Presently, she is Chairperson of Women Doctors Wing of IMA Prayagraj. She is Vice President of ISOPARB Prayagraj and Honorary Secretary, Allahabad OBGYN Society. And she is an active member of all the conferences and everything we do at Allahabad. Welcome, Dr. Chitra. With this, I request Dr. Chitra, please kindly introduce speaker of today, Dr. Jaiswal Patel, ma'am.
So our coming to the next very, very important topic, managing sickle cell anemia during pregnancy. We all know that sickle cell anemia, it is associated with an autosomal recessive disorder, sickle cell disease. And India contributes to 14.5% of the global burden of sickle cell disease, though the cases of sickle cell trait are much higher. In 2021, a GPT study estimated all age rate for sickle cell disease in India, 89.6 cases per million. Sickle cell anemia presents unique challenges during pregnancy to mother and baby. Mother is prone to develop preeclampsia, infection, or the pre-existing anemia can be further exaggerated. She can also land in some critical conditions like acute chest syndrome and episodes of vaso-occlusive crisis. Similarly, fetal outcome can also be affected. It may lead to miscarriages, IUGR, stillbirth, or preterm birth. Now, to enlighten us on this very, very important topic, we have brilliant speaker with us, Dr. Jaiswal Patel, Professor cum Project Officer, PPC, Department of OBGY, Vimsar, Burla. Madam is affiliated to many significant society of OBGY, and at present she is Vice President of National ISOPARB and President of Burla OBGY Society. She has many awards and accolades to her credit, including 4 gold medals and Best Graduate Award in MBBS, Best Free Paper in Senior category in 33rd ISOPARB National Conference 2017. She also got Legend in Gynecology Award in National Wisdom Conference, Kolkata 2024. She also has many publications to her credit, including more than 25 original research articles and case reports in various journals. And she's also contributed more than 7 chapters in different books. And she also run a cancer awareness program on Doordarshan. We welcome you, ma'am, and please enlighten us with your talk.
Thank you, madam. Thank you. My namaskar to one and all, respected chairpersons of my session, or the organizers of this Scientific Sangam 37, which is in collaboration with Prayagraj, Kanpur, and Burla ISOPARB chapter. and all the delegates who have joined in this event. And my special regards to our chief guest, Dr. Meera Agnihotri Madam. And I'm here to say something about this common disease, burning problem, that is the sickle cell disease in pregnancy. So sickle cell disease is a very common disease, as Dr. Chitra Madam has told. It is one of the common genetic disease of autosomal recessive variety, which can present in any age group, any sex, any religion, and any country and anything. So it is a global disease. But there are some areas where it is more common, like the South Africa, the Mediterranean countries, the Southeast Asian countries. In India also many states like the this Odisha, Chhattisgarh, Jharkhand, Bihar, and in some of the states also, some of the areas are, the districts are also having common in our state. The Western Odisha is common in the sickle cell disease, and it can now happen in any age group, because now the communicability to different countries, the marriage in the different races and communities can happen. So it is not confined to a single race or single areas. So it is a global disease. And to aptly to take this disease, this year the theme for the sickle cell disease is hoping through progress, advancing sickle cell care globally. So that means it has emphasizes that it is not, we have to think globally to combat this disease. And 19th June every year it is celebrated as the World Sickle Cell Day, and this emphasizes that we should all come together through our everyone's amplified voices, raising the awareness, and we should reduce the stigma and drive meaningful change for the millions of affected populations of this disease. And aptly, the government of India has taken this as a challenge mission. And the mission they have launched in the year 2023, on 1st July 2023, our Honorable Prime Minister Sri Modi ji has launched this program. There is a National Sickle Cell Elimination Mission. So we are in a now mission mode to eliminate this disease, so that it will not be a significant public health problem. So the mission should be, the target is up to 2047. Our country should be of we are in a sickle cell elimination phase. So to introduce my topic, it is one of the most common inherited autosomal recessive single gene disorder. Sickle cell syndromes and sickle cell anemia are a little different. The sickle cell syndromes, there are other varieties of the sickle cell hemoglobinopathies are there, which can manifest as sickle cell disease, like not only SS, but sometimes SC, SD, SRF, and S beta thalassemia combined. So we can say it is heterozygous also. They are in the sickle cell syndrome. So though the sickle cell disease can affect any groups and any department are involved in managing this disease, but our fraternity is more so important in managing the women with sickle cell disease, because having a host of the maternal and the fetal morbidities and the mortalities. So hemoglobinopathies are the disorders of the hemoglobin, and there is a structural abnormality. In the sickle cell, there is a structural abnormality, but in the thalassemia, there is deficient synthesis of the globin chain. But when there is a combined variety, there is a double heterozygous sickle cell and beta thalassemia combined, it is a double burden. That means there is a abnormality in the structure and also decrease in the synthesis. So sickle cell hemoglobinopathy is classified as the two varieties, sickle cell disease and the trait. The disease is called SS, but the combined heterozygous that I have already told, and the sickle cell trait is the AS or asymptomatic carrier. In pregnancy, mostly the sickle cell trait do not manifest any such abnormality, except there is increased risk of the asymptomatic bacteriuria and microscopic hematuria. And nowadays, different studies are saying that there is higher incidence of preeclampsia in the sickle cell trait women. So there is not, of course, meta-analysis, but probably with the different studies, you can know that the sickle cell trait are also having high risk of the preeclampsia. But sickle cell disease is a dreaded complications in the pregnancy, both for the mother and the newborn and the fetus. So a big brief pathophysiology. So sickle cell are they are rigid and sticky that adhere to the small blood vessels and obstruct it, leading to the tissue ischemia and painful crisis. The lifespan of the normal RBC is around 120 days, but in case of the sickled RBC, it is around 5 to 10 days. It's such a less number of days the lifespan is. And they are also too rigid and they're sticky. They form rollo in the capillaries. The deformed sickle cells, they are friable and they have a very short lifespan and leads to hemolysis. And there is a complement mediated hemolytic process will also occur in the systemic circulation. So to diagnose the sickle cell disease, we can do the simple sickle slide test, which the report is available after approximately 48 hours by putting the 2% sodium metabisulfite, the 2 drops of the blood over a slide, and we have to cover it by a cover slip, then see it over the microscope. So it is a screening test. But other tests that can be done are the hemoglobin electrophoresis, which can depict the variety of the hemoglobin variant, like the whether AS or SS like this. But HPLC is much more valuable because it can also determine the level of the abnormal hemoglobin. The other types of the hemoglobin can also be known. The high performance liquid chromatography is a very good result, and it is also now available quite rampantly in many of the centers to do this HPLC test. And the higher tests are the DNA PCR and DNA sequencing that can also be done, but mostly we are confined to the either these three: sickle slide test or electrophoresis or HPLC. But nowadays the point of care test is also being advocated by Government of India, so that the paramedical workers in the field, they can while they are examining the antenatal mothers, they are doing the test then and there, like small pregnancy kit like card, where they can put 2 drops of blood and the report is available within just 5 minutes. But that has to be confirmed by HPLC. This is just point of care test, which is screening test. Then coming to the manifestations. So in the manifestation point of view, we can divide into 3 categories: one is the steady state, then is the acute manifestation, and the chronic manifestation. So in the sickle cell, many of the women are in the steady state. They remain in a mild to moderate anemia, around 7-8 gram hemoglobin, with minimal limitation of the activity. And so there might be some mild degree of the jaundice because of the intravascular hemolysis, and there might be some splenomegaly might be there. So the sickle cell disease patient, they have a different types of manifestation. Some are, though there might be having the sickle cell percentage of suppose 60% or 70% of sickle cell, but they may not have many symptoms. But the same type of the other categories of women, where there might be sickle cell of 41% or 45%, but they might having many of the symptoms. So it is not known why some are having so many symptoms, why some are having less symptoms. Then this is about the steady state. And the acute manifestation in the pregnancy, there is very high chance of the acute manifestation in the form of different crises. The most common crisis, the painful crisis or the vaso-occlusive crisis. And sometimes there may be acute chest syndrome, which is one of the dangerous variety. Other symptoms, other manifestations are hand-foot syndrome, that is dactylitis, inflammation of the distal portion of the digits, swelling, painful areas, and there might be sometimes ischemia, necrosis also that can happen. So another crisis are hematologic crisis, where there might be splenic crisis, there might be aplastic crisis. So the splenic crisis, all of a sudden the patient will have a very low hemoglobin. By the splenic sequestration, the hemoglobin will suddenly drop to the steady state to around, suppose 8, you are having 8, now it can fall to 4 or 5 gram like this. Very dangerous thing for the patient also. Aplastic crisis, suddenly there will be bone marrow suppression, mostly it is due to parvovirus infection. And there may be abdominal crisis, it is also painful crisis. So during pregnancy, if the patient is having an abdominal crisis, it's very difficult to differentiate whether she is having a false pain or true pain, or whether she is having any other abdominal conditions like the pancreatitis or appendicitis. It's very difficult. So in case of sickle cell disease, to evaluate the pain, abdominal pain is very a difficult task. Then there might be sickle cell hepatopathy. Sickle hepatopathy means normally in the steady state, the bilirubin level is around 4 or 5 like this. But in the sickle cell hepatopathy, the patient might be having a very high level of the bilirubin, 16, 20 milligram like that. And these patients are very prone for the infections, especially capsulated organisms like the pneumococcus, meningococcus. That's why they need vaccination. And there is also hemolytic crisis, and it is a very common thing. Hemolytic crisis can happen, and a megaloblastic crisis, and there is the stroke. There either ischemic stroke or the hemorrhagic stroke, both can happen. But ischemic stroke is much more common because of the capillary blockage by the sickle cells. Then in the male priapism, it is not for the females. Also, there are so many acute complications that can happen during pregnancy. Then coming to the chronic manifestations, there will be impaired growth and development of the persons. There will be skeletal changes, cardiovascular system dysfunction, pulmonary hypertension. And all of us know that primary pulmonary hypertension is one of the most dreaded heart disease in the pregnancy. And in the sickle cell, this pulmonary valve that will be affected, and that will pulmonary hypertension will be there. The pulmonary circulation will be affected, there will pulmonary hypertension will be there. So when it is added to the sickle cell disease, it is again a high risk. Then there is very high chance of gallstones formation in the form of pigment stone. There is renal impairment with the papillary necrosis, and mostly they used to take the analgesics, and the analgesics may cause the renal impairment and necrosis. There might be CNS dysfunction, there may be leg ulcers, and there might be also ocular changes. So coming to the management proper, I have divided into 4 categories. One is the preconceptional management, the antenatal management, the intrapartum, and the postpartum. So the preconceptional management is one of the important things as far as our elimination part is concerned and for the counseling part is concerned. So whenever a woman comes with the sickle cell disease or other cyst trait also, we have to definitely test the partner status, partner's hemoglobinopathy status, especially by HbA1c. So this is needed to know this antenatal, the preconceptional screening for to know whether the babies or the unborn baby is sickle cell disease or not. So there are some situations where this can be done, like suppose both partners are sickle cell trait, or one partner is having sickle cell disease, or other partner is sickle cell trait, or suppose one partner is having disease and other partner is having any other variety of the hemoglobinopathy. So like this, vice versa. In this way, so our aim is to detect sickle cell disease of the unborn fetus. If the combination is in such a manner that there is no chance, but if there is a chance that every baby will be sickle cell disease, again there is no need to do the test. But whenever there is chance of normal fetus or sickle cell trait or the disease fetus, then we can this test. Then we have to update the vaccination status, whether they have taken the vaccination for the pneumococcal or meningococcal vaccination, and they should take the folic acid regularly during the preconceptional period, and medication they have to stop some medications. So what are the medications they will stop? Like one is the this hydroxyurea. So commonly sickle cell disease they takes the hydroxyurea, and the RCOG guidelines say that 3 months prior to planning for the pregnancy, the hydroxyurea has to be stopped in view of the teratogenicity. And during the pregnancy period also, it has to be stopped. So we have to counsel about these things. Next thing is, if she is taking any SE inhibitors or anti-angiotensin receptor blocker, these are the common antihypertensive. They are commonly used by the sickle cell persons. So we have to stop these 3 medicines. Then we have to ask them to how do they have to avoid the crisis, because there are certain aggravating factors I will tell. So they have to avoid the crisis. They should seek medical advice early whenever there is any problems like infection or these things. And if they do not want the child in the contraception, or they want to delay, they have to add the contraception. And you have to think of the iron overload. In the thalassemia, there is very high chance of the iron overload compared to the sickle cell. But sometimes the sickle cell also, there is also possibility of the iron overload if they are taking very high, very large number of the blood transfusions. So we have to think of the iron overload. So we have to do the serum ferritin test. So there are so many complications that can happen. There is the maternal spontaneous miscarriage, preterm labor. So all these things you have to counsel the patient and their family members that such and such things can happen. Spontaneous miscarriage, preterm labor, preeclampsia, antepartum hemorrhage, infection, thromboembolism. And for the baby also, there is intrauterine growth restriction, stillbirth, and perinatal death. In the antenatal management, it needs a multidisciplinary approach by obstetrician, trained midwife, hematologist, and sometimes also intensivist. The ICU patient may need ICU care. So we have to screen for the end organ damage like the pulmonary hypertension, liver function test, iron overload, retinal screening, hypertension, and renal function status. So there are some factors which may precipitate the crisis, like the physical and emotional exertion. So you have to, patients should be counseled to avoid these things. Then we have to infect, we have to avoid the infection. So simple a gum infection or simply a ear infection can also aggravate the crisis. Then exposure to extreme cold or extreme heat, both are hazardous. Then dehydration. So they should be properly hydrated. Then pregnancy itself is a precipitating factor. Then acidosis, surgery and anesthesia, and discontinuation of the hydroxyurea. If they discontinue for a prolonged time, there is also a risk for the precipitation of the crisis. So medications that are commonly given during pregnancy are the folic acid, prophylactic antibiotics, and have to stop the unsafe drugs. Iron supplementation. So regarding iron supplementation, the oral iron can be prescribed, but not the parenteral iron. Parenteral iron is strictly contraindicated in the hemoglobinopathies, any hemoglobinopathies. Oral iron can be given the preventive dose, but if you are needing a therapeutic dose of the oral iron, better to have the serum ferritin level. Then the low dose aspirin has to be given because these women are high risk to develop the this preeclampsia, and they are also high risk to develop the intrauterine growth restriction. And so aspirin is a vasodilator.
Dr. Tripathi, would you like to share your views on sickle cell?
Yes, ma'am. This part of Odisha, day in and day out, we come across these patients. Even the most complicated cases we deal here. All the symptoms we have read in the books may be acute chest syndrome, may be stroke, may be painful paralysis, hemolysis, every patient we are dealing with. Just recently, a few days back, we have recovered a patient who was in our ventilator for almost 1 month, and she survived. So she was almost a near mismatch. So this is not a new thing for us. So we like to share our knowledge with other parts of the world and other parts of India, what they are doing there and what they are saying there.
So moving forward on this management of this pregnancy with sickle cell anemia, so it needs a multidisciplinary approach, not only by obstetrician, but also by trained midwife, hematologist, and sometimes also the intensivist. And we have to screen for the end organ damage like the pulmonary hypertension, liver function, iron overload, retinal screening, hypertension, and renal function. So there are so many precipitating factors for the sickle cell crisis, like the physical and emotional exertion. You have to counsel that women that this should be, these things has to be counseled properly so that they can avoid the crisis. And any infection, even a mild variety, may also aggravate the crisis. Exposure to extreme cold and extreme heat, both are dangerous. Dehydration is also a dangerous thing. Then pregnancy itself is a high risk factor for the crisis. Acidosis, any surgery and anesthesia are also risk factors. And discontinuation of the hydroxyurea for a prolonged time may aggravate the crisis. Next slide. So many medications that should be taken during pregnancy are the folic acid, then prophylactic antibiotics when we are suspecting any form of infection. And there should be a low threshold for the infection and low threshold for the antibiotic use. Then we have to stop the unsafe drugs like this. During pregnancy, hydroxyurea should be stopped. The AC inhibitor should be stopped. We have to give the iron supplementation. So regarding iron supplementation, the patient can take oral iron, that is a prophylactic dose of the oral iron. But parenteral iron is strictly contraindicated in view of the iron overload. But when they need a quite larger amount of the iron tablets in a therapeutic dose, we have to do the serum ferritin test. So in the women with sickle cell anemia, if we will avoid the iron in view of the fear of this iron overload, that might be a double burden for them. You have to do the serum ferritin test, and as and when necessary, you have to give the oral iron. So this is not a contraindication. We have to think for that. Otherwise, it will be a more dangerous thing for them. Both there will be anemia due to this sickle cell, and also there will be anemia due to iron deficiency. Both will be aggravating factor for them. Then we have to start the aspirin. We have to give the aspirin low dose 75 milligram per day. Maybe started after 12 weeks of the pregnancy up to 34 weeks, because this will prevent the preeclampsia and also prevent the intrauterine growth restriction, because sickle cell are more prone for this preeclampsia, and there is also there is rollo formation in the small capillaries which may cause this aggravation of crisis. So that will be prevented by the aspirin. So aspirin is a very good molecule for the sickle cell women. Then low molecular weight heparin, especially to the indoor patient. That is the after vaginal delivery, minimum 1 week, and after cesarean section, minimum 6 weeks. There is the recommendations to use the low molecular heparin in the indoor patient. Next slide. Hyperemesis gravidarum may happen during the pregnancy. So this is a triggering factor for the crisis. So to avoid this dehydration and acidosis, and you have to intervene them early. Next slide. So partner status, we have to screen. They may be normal or carrier affected, and the prenatal testing at appropriate gestational age has to be done. So mostly we are going for the CVS or the amniocentesis, but the NIPT is not appropriate. And NIPT is screening, it is not a confirmatory. So CVS and amniocentesis can be done when it is indicated. Our aim is to detect any sickle cell fetus, unborn sickle cell fetus. Then option for termination, if the baby turns out to be sickle cell disease, that should be option for termination. Now, if the risk, explain if wants to continue the pregnancy. Next slide. Next slide. The special advice, you have to do the blood pressure test, blood pressure measurement and urine analysis in every visit. Midstream urine for culture, because there is very high chance of the urine UTI in the sickle cell women. And so you have to do all these test. Next slide. Sonography. So sonography, the viability scan at 7 to 9 weeks. The routine first trimester scan at 11 to 14 weeks. And the anomaly scan as for the other women also. But the growth scan has to be done every 4 weeks after 24 weeks. So because in women, there is very high chance of the growth restriction. So this is a mandatory thing to assess the growth and the fetal well-being for this pregnant woman. Next slide. Blood transfusion. So prophylactic blood transfusion is not recommended because they are in a steady state. They can manage even the 7 or 8 gram hemoglobin. But when this steady state is decreased, the hemoglobin level decreased from the steady state, then you can plan or think for the blood transfusion. And the blood transfer, because they are needing the blood transfer very often, you have to do the extended phenotype and it should be free of the cytomegalovirus infection. And the blood transfer may be necessary during the surgical procedure also. Then coming to the management of the acute complications. So this is we have to think of the different crises. So coming to the acute painful crisis, the most frequent complications, 27 to 50% of the women present with the painful crisis, and it is the most common cause of the hospital admission. Next slide. So there are different, next slide. There are different, we have to assess rapidly clinical assessment like the critical care specialist, fetal medicine specialist, anesthetist, history, the nature of the pain, the previous attack, the intensity of the pain, the location, duration of the pain, any aggravating the relieving factors, and any signs of infection. Next. So if the patient has come with the, even with the acute painful crisis, you have to do the different blood tests like the CBC, reticulocyte count, renal function, blood and urine culture, and liver function test. Next slide. So that that can be given, is advocated by WHO. So this is for the, if there is a mild pain, so they can be counseled for the rest, oral fluids, and paracetamol tablet. It's not contraindicated. But if there is a moderate pain, next slide. Next slide. Then if there is moderate pain, weak opioids like the tramadol or dihydrocodone can be given. NSAID, there is a ketorolac, diclofenac, or the ibuprofen can be given, but it is between 12 to 28 weeks. Before 12 weeks, in view of the teratogenic risk, and after 28 weeks, with the risk of persistent doctor's arteriosus. So this is avoided. So it is given up to 12 to 28 weeks. There is severe pain. Patient may need strong opioids like the morphine, codeine, and tramadol, which can be given orally, subcutaneously, intramuscular, or sometimes also intravenous. Next slide. So the patient may need referral to higher center if the pain does not settle with simple analgesia, or there is atypical pain, new location, or generalized pain. There is shortness of breath. There is neurologic headache, confusion, seizures, or chest or abdominal pain. Next slide. So we have to monitor the patient very closely. That is every 20 minutes interval, the pain intensity, the vitals. The patient may need sometimes sedation also. Then patient oxygen saturation has to be maintained. The oxygen saturation is less than 94%. This should be supplemented with the oxygen supplementation. The pain settle down after oral analgesia. She may be discharged home. If the pain does not settle down, patient may need strong opioids and may need hospitalization. Next slide. Fluid management. So the patient should not be dehydrated or should not be overhydrated. So the strict input and output fluid chart is mandatory. The fluid need is around 60 ml per kg per day. Like this should be managed like a heart disease patient. And the fluid of choice is ringer lactate or normal saline, and not the 5% dextrose. And oxygen saturation by a facial mask or the nasal prong, it can be given. And oxygen saturation has to be maintained beyond 94%. Next slide. So thromboprophylaxis, the low molecular heparin. Next slide. So it is up to 7 days in the vaginal delivery and 6 weeks following the cesarean section. Sometimes may need adjuvant therapy, that is antipruritic, some laxatives and antiemetic patient may need. Acute chest syndrome is one of the dreaded complications, second most common complication, and it is characterized by tachypnea, chest pain, cough, shortness of breath, and new chest infiltrate and the chest X-ray. The symptoms simulate like pneumonia. That early recognition is mandatory, it is vital, An IV broad spectrum antibiotics is necessary, and you have to maintain the blood. If the hemoglobin is less than 6.5, you have to give the blood transfusion. And exchange transfusion is here it is necessary. There are two conditions where exchange transfusion is necessary. One is the acute chest syndrome, another stroke, where this is useful to control this crisis. Next. So acute hypoxia, pulmonary embolism is likely. So hematologist for exchange transfusion, critical care specialist for ventilatory support, and low molecular weight heparin is considered. Next slide. Coming to intrapartum care, so induction and elective cesarean section after 38 is in the normal growing fetus. But if the baby is having growth restriction or there is certain Doppler change, then it may be done earlier. So last 2 weeks is very vital. The patient should not be post-dated. The delivery should be planned by 38 weeks. Sickle cell disease is not a contraindication for vaginal delivery or vaginal birth after cesarean. And the cesarean section is according to the obstetrical indication, not due to the sickle cell disease. According to the obstetrical situation, the relatives are counseled about the risk to the mother and the fetus. It should be taken a high risk consent. Cross-match blood should be ready in the OT, especially PET cell. Women nursed with propped up position, and women should be kept warm and given adequate fluid, and continuous monitoring is necessary. And venous access should be there for the IV fluid. Next slide. So in the previous slide, madam. Previous slide. In the intrapartum care.
Slide. No,
Yes,
previous slide. Previous.
Yes, so another thing that I have forgotten, in the intrapartum care, the patient needs increased oxygen demand. Oxygen demand is increased, so we have to supplement with oxygen therapy. Observe the vitals and temperature. Routine antibiotic prophylaxis is not recommended, but if there is sepsis, infection is there, chance is there, you have to give. Then if the forming temperature, you have to give the broad spectrum antibiotic. Then second stage has to be cut short by the ventures or the outlet forces, but the criteria has to be fulfilled, otherwise that will be again more disastrous. The third stage will be managed actively, but the methyl ergometry is contraindicated. You can give the misoprostol, and the pain management with opioids, but pethidine is not recommended in view of the convulsion, and regional anesthesia is recommended for LSCS, not the general anesthesia. Next slide. So the postpartum care, there might be complications like the subinvolution, puerperal sepsis, congestive cardiac failure, thromboembolism, and lactational failure. So men whose babies are at high risk, so that means you have to skim the newborn screening also. The immediate cord blood of the neonate has to be sent for the SPLC. So that a routine newborn screening should be done, and you have to maintain the maternal oxygen saturation in the postpartum period also, and adequate hydration, low molecular heparin. Already I have told, high level of the care and vigilance to be maintained, and contraceptions should be advised. And here the combined OCs are contraindicated in view of the higher risk of the thromboembolism, but only progestogen contraceptives like the Serajate or the Depo-Provera or levonorgestrel ICD can be given. And if they want permanent sterilization, it can be offered. But the combined OCs contraindicated. Next slide. So coming to the end of my presentation. So the take-home message is, it is a high-risk pregnancy, a multidisciplinary approach. The management protocol of the hospital should be established, and the trained staff should be there to manage this pregnant women. The vigilant care throughout pregnancy, labor, and postpartum period. Proper risk counseling and consent at each stage is advisable. Then hydroxyurea and ACE inhibitors are not given during pregnancy. The pneumococcal and the influenza and swine flu vaccines are advocated, and folic acid, low-dose aspirin, prophylactic penicillin are advised. So thank you all for patience hearing. So we should take proper care of these women. They are high risk. We have to think from the preconception to the postpartum period, so that we can get a better, at the end of the childbirth, we have a healthy mother and the healthy baby. So thank you all for your patience here.
Thank you so much for the wonderful talk, ma'am. Tripathi sir, would you like to add something?
First, I'd like to thank the organizers, especially Dr. Reena Khanna, Dr. Amita Tripathi, for so well-tailored, for managing a well-tailored webinar like this. Just because Dr. Ojaswini, she is a genius, she has almost described everything in details. Rather, I will say more than details. Just a few words, if I like to say, we should not look at the pregnant mother having sickle cell anemia. We should look a bit earlier, before she gets marriage. So counseling is a very, very important part, so that we should not allow a mother, sickle cell mother, to have the complications of sickle cell disease, may it be either painful crisis, VOC or acute chest syndrome, or VT, that is vascular thromboembolism, like this. So if we can, as Dr. Jasini was telling, if we can prevent the further generation to have sickle cell disease, there should be a strong counseling for the would be getting married couples not to marry a partner having a sickle cell disease or a trait. And one more information I would like to share rather, the patient, the mother, those who are having sickle cell trait, they are blessed in some kind or other because that affects or that acts as a preventive measure for preterm birth, even IUSR or even parental mortality death. Moreover, there are other options we should give them, like the donor sperm, if at all by chance they marry, if a partner, both the partners are having sickle cell disease, we should counsel them even for donor sperm, donor ovum, or PGT, or even surrogacy if the mother cannot bear a child herself. That should be open to them. And the last but not the least, the future is there because the newly upcoming things like bone marrow transfusion, genetic therapy, gene therapy is also started in different countries, and the this therapy is also started in many countries. So these things, the future is coming with good things. So best thing is to prevent and prevent and prevent. So counseling is the most important part. That's I like to say. Thank you again, all the faculties as well as the participants for joining this webinar. Thank you, ma'am.
मीरा मैम या मंजू मैम कुछ कमेंट करेंगे क्या?
या अमिता, वैसे मीरा जी से बात पहले कमेंट करें फिर उसके बाद मैं करती हूँ. मीरा जी हैं?
मैम अभी लग नहीं रहा है मैम, वहाँ पे ज्वाइनिंग तो है बट आ नहीं रही.
Achha, I would simply like to say that it is better to suspect and diagnose the thing because the conditions can become serious later on. And the two main things which are responsible for the problems are basically the anemia and the blockage of the small arteries or blood supply. So if we have to be very, very careful, and I think Dr. Tripathi has given the whole review, what should be done recently, what we can do. So this is what is very important. I think Jaswini, very, very enlightening lecture. Thank you. Thank you, everyone.
So thank you, Jasmine ma'am, for enriching our knowledge about this sickle cell anemia. And moving towards the next session, I will hand over the conduction to our communicator of ISOPARB Prayagraj, Dr. Parul Khanna. Right now, she is senior consultant at an IVF specialist at South End Nova IVF Center. Welcome, Parul, to conduct the next two sessions.
Thank you, ma'am. Very good afternoon to the esteemed faculty and dear delegates. Without wasting more time, we move on to our third session, which is a talk on managing gestational diabetes mellitus with emphasis on medical nutrition therapy. And our speaker for the session is none other than Dr. Kiran Pandey, ma'am. I would like to invite the chairpersons for the session. Professor Obs and Gynae, GSBM Medical College, Kanpur. Scientific Secretary, Kanpur Obs and Gynae Society 2023-2025. She is founder member of Kanpur Menopause Society and ISOPARB Kanpur. Core committee member of Safe Motherhood Committee. She has been a master trainer for CE, MONC, IYCF, New York Contraceptive and RRTC and Dhira Project. She has more than 30 national and international publications and has been speaker in various conferences. And she has been recipient of various awards like Great Teacher Award, FOGSI Achiever Award, Manyata Champion Award, and COGS Icon Award. I welcome you, ma'am. Our second chairperson is Dr. Leena Baru. Ma'am is Professor, Department of Obs and Gynae, Vimsar, Burla. She is Secretary, Burla Obs and Gynae Society. Ma'am is life member of FOGSI, ISOPARB, IMA, ISAR. And she has various publications in national and international journals. She has also been trained in chorionic villi sampling for prenatal diagnosis. And she has been trainer for certificate program in community health Council of Paramedical Science of India, Comprehensive Abortion Care. I welcome you, ma'am. I now request Dr. Shelly Agarwal, ma'am, to introduce our topic and speaker.
Thank you so much, Dr. Parul.
Thank
And first of all, let me thank my respected teacher, Dr. Manju Varma, madam, Dr. Ranjana Khanna, and Dr. Amita Tripathi for having me on the board, because Allahabad carries a very special role in my life. I'm alumni from Allahabad. I've done my MS from that college only. So it is always a pleasure to be with all of you. And now we are discussing very important non-communicable disease, that is GDM, and it is affecting the pregnancy, as we all know, and the prevalence is rising in India like anything. Previously, we used to see only 2-3 cases in a week, but now we are having 4-5 cases in each day in our labor room. And to speak on this topic, I don't think there can be a better person than Kiran Pandey ma'am can be possible. So it is our privilege to have Dr. Kiran Pandey ma'am on the board. And although she doesn't need any introduction,
Thank you.
and I'm very proud, privileged to work under her guidance in Department of Obs and Gynae when she was HOD. And ma'am is chairperson of Medical Education Committee, FOGSI. Currently, she's holding this post. And she's also president of Kanpur Menopause Society. She's president of AGOI UP. And ma'am has a very extensive CV, which is very exhaustive CV also. Ma'am has received very awards.
I don't think we all are a family. So it's perfectly okay if we go ahead with it.
So over to you, ma'am. We are waiting to listen to you.
Thank you.
Kiran has got a very decorated CV.
Oh,
Yes, ma'am.
Thank you, Dr. Ranjana. But decorated person in front of me, my inspiration is you. At the outset, I'm really thankful to our Allahabad society, and my regards to our chief guest, Dr. Meera Agnihotri, who's my mentor and teacher of teachers and our inspiration. I can see Dr. Manju Varma here, Dr. Tripathi here, and so many of the friends who are there. Dr. Ranjana, as you said, I will take the first part, MNC, the medical nutrition therapy. Now, I've also taken a little bit about oral hypoglycemics, but I have not been able to merge them. So I'll take a small break and then start with that and just give a little bit of it as you wanted it, actually. But because I forgot, and if Amita would not have told me today, I would have totally missed everything. So let me share my screen. Is my screen visible?
Yes. Yes.
Okay. So medical nutrition therapy in hyperglycemia, which is the basically term used these for it. So let's start with it. I'll go in a short because although everybody knows about it, but still it requires a little bit of revision to talk about these things. Gestational diabetes mellitus, we all know it is a disorder of glucose intolerance. And basically what I wanted to say, it involves 3 aspects of metabolism. One is insulin resistance, second is insulin secretion, and third is increased glucose production. So although I'm not going to go into too much detail of the oral hypoglycemics, but if we have time and go, then the drugs which are these days being discussed about them, which are planned to, they all are working on these different aspects. So that is why this becomes important. Now, this insulin resistance is again important in the sense that it goes on progressively increasing until the delivery, and therefore the values do change. And the prevalence, as Shelly was also talking, that it is increasing, and depending on the different reasons, it is from 1 to 14%. If we just define it like in that way, so then we can say it is a metabolic disorder of multiple etiology, which is characterized by chronic hyperglycemia resulting from an absolute deficiency of insulin secretion or a reduction in biological effect effectiveness of insulin, or maybe both. Both are working there. So any of the thing may be total deficiency, reduction in effectiveness, or both may be combined together, which may be operating. Now, this is the just to give you the overall prevalence, but let's basically see these areas are the highest one. But if we see in the India, this is also quite a significant one. And when we see then next 30 years, it is seen that the 66 million population would be affected globally. And in fact, India is going to be the capital of diabetes. Now, why we are worried about it? Because it causes both maternal complications, and side by side, it also causes a lot of fetal complications, which are very important. It can cause diabetic ketoacidosis, deterioration of, if the patient was having diabetes, not the GDM, but otherwise, then it can the deterioration of retinopathy, nephropathy. And in those cases where we are using like treatment insulin, which is a most important drug in pregnancy, hypoglycemia can be there in other obstetric complications like spontaneous abortion, preterm birth, PIH, hydramnios, shoulder dystocia because of the macrosomia, all can be there. And the fetal complications, again, they are of very grave significance, like fetal distress, and even death can occur. Congenital malformations, which is actually more common in cases of when the patient is has a diabetes before that. Maybe known first time, that may be one there. Macrosomia, and because of that, birth injuries due to shoulder dystocia, delayed fetal development, neonatal, many complications. So it's not that we are managing in the antenatal period. Once the baby is out, even then there are lots of things. And which our pediatric colleagues face, like hypoglycemia, hyperbilirubinemia, hypocalcemia, polycythemia, even RDS. Hypertrophic cardiomyopathy of offsprings is also a complication, and these children, they later on suffer the diabetes in they may develop diabetes in their life, and obesity. That's a fourth hypothesis works there. So the impact of GDM on the maternal and childbirth is both short-term as well as long-term. If we see we are already by these complications, you can see it's significantly increased risk of maternal morbidity and mortalities because of these various complications is there. Preterm, I've already talked to you. The WHO says the cost of inaction against the NCDs outweighs the cost of action for any country in the world today. So that is a very important statement. Long-term effect, as I was saying about it, that there is highly increased risk of NCDs like diabetes, obesity, hypertension in this mother. And then the fourth hypothesis, and the fetus also, there are complications. These 50% of mothers with GDM, they develop type 2 diabetes within 5 years. And about the faults, the child is up to 8 times more likely to develop type 2 diabetes if the mother has untreated GDM. And that is why it becomes very, very important. And there's a very good statement which I read somewhere or heard somewhere, that we should manage the diabetes or any complication in pregnancy in such a way that fetus should not even know that her mother had diabetes in pregnancy. So this is how this much good control is important. Now we all know about the universal testing. So the first screening is in these days, with all that many discussions and meetings and everything, researchers have gone, and finally it is almost universal GDM screening of the pregnant woman has to be done. And the first screening is in the first trimester, whatever the visit, whenever the patient comes, actually that is the first visit. The second screening is 24 to 28 weeks, and now it is fully recognized that the 75 gram OGTT, or we call it DIPSI test, is the 90% come out to be negative, 10% who may come out to be positive. Their first thing is MNT counseling, on which we'll focus. And if 80%, if the properly actually they behave, then 80% might be controlled if it is actually the GDM only, not that the patient was not knowing it. If it remains still uncontrolled, then we have to go for other treatment like OHAs and insulin. Of course, insulin is the first choice, but OHAs has become a new thing of talk, and that we'll try to discuss. Now, we have to make the patient understand why the diet is important, because you see, basically pregnancy hormones, they are causing the increased insulin resistance. They build up glucose. And so the insulin is needed to break up more glucose. Glucose is coming from the food also and through the pregnancy hormones. So now the two sources. Now this more glucose is being released from the liver. And then the stress of the pregnancy is causing the increase in adrenaline and glucagon. And so again, so the three sides, the glucose is being put into the blood circulation, and therefore more insulin is required to break down this glucose. Now, what does FIGO recommends about it? FIGO says that the design an appropriate diet with respect to pregnancy in such a way that the BMI or the desired body weight, physical activity, habits, personal and cultural preferences all should be taken into consideration. We can't go on one strict rule. And universal routine follow-up and diet adjustment throughout pregnancy to achieve and maintain the treatment goals of training, education, support, follow-up of the qualified dietitian expert, because all the time the clinician do not have all the time so much of a time to explain them. So dietitian role also very important in telling them the control of the weight, control, food records have to be done, carbohydrate counting, healthy food, physician, physical activity, all have to be seen. And you can understand this by this, you know, all the diabetologists, they do keep a dietitian. Similar way, if something happens like this, we should be take their help. That will always guide the patients. Now, MNT for GDM is basically known as carbohydrate controlled meal plan. It is not carbohydrate deficient. It is carbohydrate control meal plan. Because why I'm emphasizing it, because many a times what happens if the patient is told, some are so conscious or oversensitive, they will completely stop the carbohydrate. But friends, carbohydrate is all very important for the growth. So that is the thing, because adequate nutrition and appropriate weight gain in the fetal being is also important. At the same time, we have to also keep that what are the cultural preferences I've told you, and we also have to prevent the nutritional ketosis. So basically, it is a very balanced, a typical balance has to be there. So weight management will be there, physical activities, they are the initial, the mainstay of the treat management. Now, why the food type matters? Because food change into the blood. Now, this is an important thing to understand. Food change into blood glucose from carbohydrate in 15 minutes to 2 hours, where from protein it takes 3 to 5 hours, and fat it almost less than 10% occurs for that. Now we get blood glucose from all the things. The idea is, all of you know friends, that we do not want insulin peak. That is harmful. So those carbohydrates, which I will explain you in the later slides also, the low glycemic index food, or we want carbohydrate from protein, other sources, that will help us in actually maintaining the proper balanced the controlled diet. And the carbohydrates come from everywhere, that you know, I do not have to go into detail of that. The breads, the fruits, the milk and yogurt, beans, vegetables, snacks, everything is there. Now, so the energy recommendations, that's again a thing to be important in keeping in view of the carbohydrate controlled diet, that there should be no increase in calorie intake in the first trimester, because this first trimester doesn't need extra energy. In the second anthrust, we need 350 kilocalories per day. If the person is having twin pregnancy, then it has to be double 700. A modest calorie restriction of 30 to 33%, or between, we can say that 1600 to 1800 kilocalorie per day is advisable if we want to keep the weight gain also in under control, and we want to avoid the ketosis also. So not too much crash dieting or something, otherwise there will be ketosis. Calorie restriction of less than 1500 calorie or 50% restriction is not recommended. That's what I want to keep, because it will cause ketosis. Now, carbohydrate recommendation a little bit more, that it ensures the fetal brain development and functioning. So minimum of 165 gram carbohydrate per day, that is 40 to 45% of total calories have to be there. And for that, 3 meals and 3 to 4 snacks, which can be given 2 to 3 hours apart. This is the basic pattern which should be taken. And low GI index foods, that is, they reduce the postprandial the peak and the glucose levels also. Protein with meals and snacks, if we keep it every time, that this controls the glucose release to a controlled way. So wide inter-individual variability also has to be kept in mind. And I will again repeat it, avoid over-restriction. Now, low to moderate GI foods, patient might ask, although you know it, but you have to tell them that non-starchy vegetables, whole fruits, dairy products, whole pulses, sprouts, whole grain, cereal, barley, etc., millets, all they are very important. So this is how we can keep a chart of like this into our OPD and show it directly. You see to it, this is what, and you can take a photo of, you can also tell them. Now, the millets and horse grams, they are very important. And just to, you can make a dosa of it also. So that is something. Now, help protein, I told you, this helps into making a good control. And this is how we can also, we can teach our dietitian or assistant to explain then what is the one serving means. And one serving means the 15 gram of carbohydrate. So which is like 1 grain of the like bread and the 1 fruit apple or the 1 glass of milk, they all are equal. So now when we explain them to take 1 serving, either of these, not all three, one of the 3 she can take. And overall thali concept, all of you must be knowing it. We have to basically give them, and the lunch and dinner, the 1 serving of the fruit, half portion of thali with the vegetables, out of the half, 1/4 by the lean meat and protein, and 1 by the cereal. And then she can have a dairy product, but skimmed one, which is very important. Now the food exchange list, I told you, either of these 3 patient ko we can explain ki ye barabar hai, you can take either of these, kabhi ye add kar liya, kabhi ye kar liya, so that variety bhi ho jaye. Otherwise they become, they tend to then break the rules if we are not giving them any exchanges, etc. So 11 to 12 exchange in a day would help to achieve the carbohydrate target of 175 grams. That's the way ideal thing is. Dietary fiber becomes very important, 20 to 40 gram, because this is from the grains and dairy, and this helps in preventing the constipation also, and also helping in satiety and stabilizing the blood glucose. Now next comes the protein recommendations, which is very important for the synthesis of placental, fetal and maternal tissues, and 20% of total calories should be taken by the protein. And this helps you, I told you, and flattens the glycemic response of the food and controls the spikes. Then the total, the daily requirement of the protein is 9.5 gram protein per day in second trimester, which comes to about 22 gram protein per day. And we know the sources: curd, yogurt, paneer, egg, pulses, sprouts, soybean, nuts, lean feet, etc., etc. The change in pulse cereal ratio from 1:7, which is in the standard diet, changes in the pregnancy, second and third trimester, to 1:5 and 1:3, meaning by the cereal is becoming less and the protein is becoming more. So this will help into the patient more. And how we can increase, these are the some examples by which you can ask her to add these foods into her and they can improve the protein content. Basically, but one thing you have to remember, if she's having some diabetic nephropathy or some other contraindications, then we will have to lower it. So this history should be asked. She's not having any other problem. Now, fat recommendations, which accounts to around 30 to 40% of total calories. And basically, MUFA is preferred compared to saturated fatty acids. And this is optimal adult fetal. I mean, the fat is also important for the brain development. So that's important to be, that it should not be totally avoided. But definitely, we have to see this omega-3 fatty acid is important. And for that, the walnut, chia seed, fish, nowadays everybody has become conscious. I still remember, I think 10, 15 years back, I was not knowing about the chia seeds and the flax seeds, but now all of us are using it to have the omega-3 fatty acids. And the nut oil, being in low carbohydrate, they are a good source of MUFA. So they protein, fiber, and the antioxidant, they should be used. Besides this, micronutrients are important. Dietary calcium intake is important. Vitamin D supplementation, iron supplementation, all are important. Folic acid, that is should be started pre-conception, 600 microgram per day, 12 weeks before we should start with it. About the certain other supplements which people do give and the companies do come limited, the evidence in the literature are less, but depends on your personal individual experience. One can use like myoinositol, vitamin D and B6, magnesium, selenium, zinc, fatty acid, probiotics. They can be given these days. At least one feeling I have that our diet is not so good these days as it used to be years, like in our parents' time. So I think so supplementation becomes very important. So the healthy eating plate, this is the plate which we have already discussed, and the colorful. The concept of having multiple colors into the thali is also very important, because that's how it gives a different micronutrients besides the protein, fat and carbohydrates. So that becomes very important. Now, a word about sugar substitutes. Now, why? Because these days girls are using a lot, so I wanted to put it. Sucralose and stevia are safest for the pregnant. But saccharin is not recommended because placenta concentrates it heavily. Aspartame must be restricted because of the hyperphenylalaninemia. And sugar substitutes cause gut dysbiosis also. That should be remembered. Now, physical activity, exercise is again important. 30 minutes per day or 150 minutes per weekly is very important. And the activity can be any: brisk walking, recumbent bicycling, or 10 minutes of seated arm exercises. Because in pregnancy, sometimes you cannot, like later on, can't do the brisk walking, etc. Then even one can sit and do the exercise, etc. That's advisable. Now, when should you continue? But once you have given a trial, how long? If 3 consecutive readings are more than target blood levels, like what is the target blood level? Fasting more than 90. If it is continuing, postpartum blood sugar is more than 120 continuously, then we have to recounsel them and found out that what further has to be given. Of course, explore that she's actually doing the treatment, following your advice or not. That part has to be seen. Now, just to give you an idea, there are, because these days Many of the young girls, they are very fond of apps. Everything is available on the internet. So there are certain apps which are available on the internet. They can download it on their mobile phone and can check their activity and their food requirement also. Now this part, I think I will leave it because this was for something else. Then strategy conclusion. So basically, I'll come to the second part of my, I'll stop here and then come to the second part of the oral hypoglycemia. Give me a minute. Yeah. So I'm little bit sorry. I'm not being, these slides are not very good, but we'll go ahead with the findings. Basically, let's are they moving? Yeah. We leave this introductory part because that is common. Now, I was telling you about those mechanism of the how the diabetes is caused. So the oral antibiotic drugs they can be of different ways. They may enhance the insulin secretion, and they can overcome the insulin resistance, which is the very common thing. They can retard the carbohydrate absorption, because I told you the third mechanism, increased glucose intake. And then there is a group of miscellaneous groups. So there are 4 types of groups. Now, don't worry, this might look a little bit very complicated. We are going to talk about only one group, which is the insulin resistance overcoming drugs like biguanide or glibenclamide, the same thing, metformin, and the hyoglitazone or pioglitazone, and these. The rest of the, because we are not using them commonly, so I'll leave it. I don't. So the first thing is metformin. Now, this is the commonly used first-line anti-diabetic medication, and we know it's have a specific effect on different organs. One of them is ovary also. And many people, and I think in Western world, many of them use in the maternal obesity also, along with gestational diabetes. Even obese PCOS and obese diabetics, we also normally use it here. The drug was named glucophage or glucose eater by French scientist Jean Stage in 1940. The sheer popularity of its use can be attributed to its ease of administration, because it is oral administrative. It is also available in the extended release preparations. Side effects are minimal. Affordability is also good. Minimal weight gain. Like when you consider the insulin, which is the ideal drug of the pregnancy till now, at least, it's an injection. No, not all patients do want to take it. And not every time the people coming from a rural area or something, there the facility is there. And many of them are so scared of even putting the injection. So that's also some barriers are there. So the standard SOPs in the 2024, which are by the National Technical Guidelines for Management of Hyperglycemia in Pregnancy, TIPSI, NICE, FIGO, all say that, of course, insulin is the first line drug of choice for managing GDM, but metformin is also recommended by them as a second line, because it is important to achieve euglycemia. It's more convenient, less expensive, requires less monitoring, and preferred, and patients do adhere to its intake. As I told you, it works by the mechanism of insulin sensitizers. It inhibits hepatic gluconeogenesis and glucose absorption, and stimulates glucose uptake in peripheral tissues. Liver को कम बनाने के लिए करा, absorption increase करा, and peripheral tissue में ज़्यादा distribute कर दिया. It also antagonizes the hormone glucagon action. So there, by all 3 multiple mechanisms, it finally controls the glucose level in the blood circulation. it is initiated as 500 milligram daily for a week, and then twice daily, and maximum dose at 2 gram. Common side effects, of course, abdominal pain, diarrhea, which can be reduced by the sustained release preparations. But just one thing you have to remember, the patient history has to be taken. If there is a liver disorder, renal problem, or cardiac dysfunction, then it is contraindicated. Now, this technical and operational guidelines, according to the Government of India, they say that the GDM is managed initially with MNT and physical exercise. And if it is not controlled with MNT, metformin or insulin therapy has to be added, and that's what we are thinking. It is an accepted medical treatment, and it can be considered after 20 weeks of gestation for medical management. It can be started at 20 weeks of pregnancy if the MNT fails to control, and I've told you the dose and how it has to be given. Now, hypoglycemia and weight gain with metformin are less compared to the insulin. That's the thing. And or less further, the extended release is further better. Insulin is, if insulin is, one more use is there, if insulin is required in very high doses, then sometimes it happens that together, both combined together helps into controlling it better. It is also useful for obese women, I told you, because this weight, it helps in gaining them less weight during the pregnancy. So the insulin sensitivity, if it is given, it also helps. So that together it helps a lot. It also reduces the chances of neonatal hypoglycemia, which is a very important thing. Failure rate is 26 to, if the failure rate of 26 to 50%, then these patients will eventually need the insulin. So the monitoring has to be done. And they're also associated, in some studies, it's in the increased incidence of preterm labor. So that has to be taken. Now, in certain cases, it has contraindication. We should always remember significant organ dysfunction. As I told you, liver, kidney, and growth, it can cause fetal growth restriction. It has not to be given in cases associated with HDP or fetal macrosomia, or the patient is already prone to preterm birth, then it is not given. Now, European Union also approves its use from preconception throughout the pregnancy. They do give. Now, outcomes are there, not a good slide. So to conclude it, I would say that for more than 40 years now, it is a routinely prescribed drug. And there are certain gray areas. It is good for obese women or polycystic diseases. The benefits and the side effects and the contraindications all have to be evaluated. Now, of course, more research is required. Then the second is glyburide. I will not like to go. I think time is also less. So let's leave this. Now, both metformin and glyburide are actually, if we say of FDA, they are not approved. However, the result of RCTs comparing these OAs, metformin and glyburide, with insulin after first trimester of pregnancy and GDM have shown no significant difference in maternal and fetal health outcomes during pregnancy and short-term outcomes in offspring. Therefore, patients of GDM who have mildly elevated blood glucose level, especially after beyond 25 weeks of pregnancy, and those who refuse to take insulin may be prescribed OAs. However, the women should be fully informed also, because this is the time of medico-legal era. So the patient should be informed that the long-term safety data are not yet available. So with this, I think so. I'm once again, thank you, Dr. Ranjana, for giving me this opportunity. And I have just tried to actually focus on the metformin. And insulin is, of course, as a very big topic in itself that needs a. So I hope I'm clear. And if any questions, I can take it.
Thank you so much, ma'am, for such a lucid talk.
I request Dr. Leena ma'am to give concluding remarks.
Thank you.
Leena, you are frozen at the moment.
I think there are some network issues.
GDM of
She's back.
Yes, one thing I like
बस
to
से मंजू जी की बात सुने.
हाँ,
you have
Leena,
given
मंजू जी का अप्रूवल मिलेगा तो मुझे लगेगा I could do justice.
Kiran, Dr. Leena has to say something. Huh?
I know she's I was waiting
Abhi,
actually.
she's there. She's there only.
She's there.
Okay,
हाँ.
okay, Manju ma'am, please आप
No, beta. You have to. You have to say.
अच्छा हाँ,
Dr.
आपका
Leena,
बीच
please.
में frozen हो गया था तो we started talking as usual.
No, nothing more to say or nothing more to add. Only one thing I like to add is that patient education is very much important. Whatever decision we are taking, if it will not deliver to the patient, then it is up to the no use. So in our OPD, we must take the help of dietitian or counselor because we don't have time to so much to counsel each and every patient. So we have to take the help of the dietitian and also keep some chart. You have prepared that colorful chart for the taking the, because we obstetrician always tell don't take this, but we don't advise them what to take. Each and every local language they need to say what they want to take, because according to the availability of the sources they need to take that much of calorie to prevent ketoacidosis as well as the fetal well-being. Thank you so much, ma'am, for your nice presentation.
Thank you, ma'am. Dr. Manju ma'am, would you like to say something?
I would like simply to say, as usual, Kiran is again the best of her, delivering a thing which is very, very complicated. She has so nicely clarified each and every point as far as the MNT is concerned, as far as the oral glycemic agents are concerned, and the comment by the chairperson that we should emphasize to the patient that this is the thing they can take. Instead of a negative feeding, I think it is better to have a positive feeding. And the other thing, if we can also calculate the amount of calories that a person can take, that will be very, very good. And there are formulas available for that. And the calorie requirement by a person can be taken by the BMR into the physical activity level plus 350 calories, because most of the patients, they come in the second and the third trimester. So 350 calories are to be added, and we can have, this formula is given very nicely everywhere. The only thing with the metformin is that the creatinine level should always be, Kiran, I think creatinine level should be taken before starting metformin.
Yes. Yeah, she said about, yeah.
Renal
that
and
has
the
to be
liver
emphasized.
kidney functions have to be seen.
Especially liver, kidney, because, and the other thing is the patient should be explained that this is a drug which can cross over the placenta. So we don't have very long-term studies to tell us. That, and you have already so nicely explained everything.
Thank you so
Congratulations.
much.
So sweet.
Thanks
Thank
to
you,
Amita.
ma'am.
She told me in the morning. I was
very nice talk, Kiran.
Yeah.
We now move on to our fourth session. The speaker for the session is Dr. Amita Tripathi, ma'am, and she will be speaking on iron deficiency, anemia, and pregnancy. The chairpersons for the session are Dr. Suman Gupta, ma'am. Ma'am is Director, Ayushya Maternity and Nursing Home. She is ex-treasurer, AOGS, ex-vice president of AOGS, and she is founder member of ISOPARB. I welcome you, ma'am. Our next chairperson is Dr. Abhilasha Kumar. Ma'am is a private practitioner at Kumar Maternity Home. She is currently treasurer of ISOPARB Prayagraj chapter, and she is a life member of FOGSI with keen interest in infertility and high-risk pregnancy. Welcome, ma'am. I now request Dr. Abhilasha to introduce the topic and the speaker.
Very good evening to all respected faculty and all the delegates. So we come to the end of this session, and the topic is iron deficiency, anemia, and pregnancy. And for this, I would like to invite Dr. Amita Tripathi as the speaker. Dr. Amita is a senior obstetrician and gynecologist of Prayagraj. She is a precious jewel in the crown of ISOPARB Prayagraj Society. She is the founder, honorary secretary of ISOPARB Prayagraj. She is the past chairperson of Women's Wing of AMA Prayagraj. She has been the vice president and honorary secretary of AOGS Prayagraj. She is the director of Allahabad Women's Health Center. And she is a recipient of many awards. I welcome you, Dr. Amita, for the lecture.
So very good evening, everyone again. And after these three wonderful sessions, I am going to speak on iron deficiency, anemia, and pregnancy. I will try to be very, very brief in my presentation. And iron deficiency, anemia, and pregnancy with reference to lactoferrin. So despite lots of advances and many very good national programs like Anemia Mukt Bharat, even today, the last National Family Health Survey that was published in 2019-2022, the 52.2%, we can say more than half of the pregnant women are anemic. And the irony is that the incidence, prevalence of anemia has increased from the last survey from NHS 4 to 5. So, and we all know what is the impact of anemia on the pregnancy outcome in reference to reduced resistance to infection, reduced ability to withstand PPH, strain of even uncomplicated labor can cause cardiac failure and predisposition to PIH in preterm labor. For the babies, they can have preterm delivery, IUGR, perinatal complication, and low birth babies. The irony is that more than 50% of women with iron deficiency anemia are not aware that they are having anemias. They think that these are the symptoms of pregnancy. So we must make them aware that these simple symptoms, if they are feeling fatigue and tiredness, shortness of breath, restless leg syndrome, these can be because of anemia, and we have to fully investigate them and diagnose them. Hemoglobin level to diagnose anemia, we all know WHO has given cutoff more than 11 for the normal, and in second trimester is more than 10.5. For if you take ICMR, mild is 10 to 10.9, moderate is 7 to 10, severe is less than 7, and they have taken also very severe, less than 4. But when we are diagnosing iron deficiency anemia, we have to look for other things also besides hemoglobin, like ferritin. If there is no inflammation, the cutoff is less than 30, and if there is inflammation, this is 100. And transferrin is raised, total iron binding capacity is raised, iron are reduced, transferrin saturation is less than 20, and mean corpuscle volume is low. What is very important to look very carefully on the CBC parameters. If the a combination of low MCV with elevated RDW can be used as a sufficient evidence to start iron therapy, because RDW has decreased in thalassemias. As we have discussed, we can go for iron studies, especially the serum ferritin. We can go for peripheral smear and bone marrow examination in special cases. So this is a busy slide. I'm not going into details. And we all know the iron requirements during pregnancy are increased nearly 10-fold during pregnancy, from 0.8 milligram per day in first trimester to 7.5 milligram in the third trimester. And iron requirement during pregnancy is about 35 milligram, and in lactation 25 milligram. So as Dr. Kiran ma'am was telling us, we have to say no and tell our patients about the locally grown things in which they are iron rich. We should know, and we should tell our patient, look, these are commonly locally available products which are very rich in iron. But the thing is that some of the foodstuffs which are relatively, if we look for the village population, which are usually anemic, they're poor in iron. Their groups like milled rice, which we take normally, the red gram or green gram, spinach, even spinach and mustard, which you think is mein bahut zyada iron hoga, they are not very good in iron. But the other things like beet greens, radish, pumpkin, colocasia leaves are either used to feed cattle or are discarded. as a waste are more rich in iron. Another very important thing that traditionally we used to cook our food in iron vessels, and has been seen now we are again going back to cast iron, and the cooking food in iron vessels increase the iron content of the cooked food. So looking into these matters, taking vitamin C and not reducing phytates and all other things, then that can help us. So the pharma industries and research, various researchers are going on to give us best molecule, best oral molecule, best parenteral therapy. And this one, bisglycinate, is good in terms of oral absorption and helping the patient to reduce anemia with less GI side effects. If you see maternal nutrition, it's not just the iron, but a well-balanced diet containing vitamins and mineral supports. Now coming to the lactoferrin, what is lactoferrin? It is a non-heme glycoprotein that binds to two iron forms, mostly ferric, with high affinity and increases the iron absorption. It plays an important role in process of iron regulation at the cellular level. What does it do? It enhances the uptake of iron by intestinal cells. As the lactoferrin molecule enters the intestinal cell through its own receptor, then iron is released from lactoferrin inside the intestinal cell and transported to circulation via transferrin. And it has a structural similarity with serum transferrin, and iron binding capacity is about 300-fold greater than that of transferrin. So thus it increases the hemoglobin and total serum iron level, thus maintaining the hemostasis of iron in body and the cells. It has another important thing. It is an anti-inflammatory activity. It does the down-regulation of interleukin-6 and can modulate hepcidin and ferroprotein synthesis. That's why it can be helpful in preventing preterm labor. And another important thing is, by virtue of free iron sequestration, it controls formation of reactive oxygen species, thus protecting cells from oxidative stress. So these are the clinical studies were shown that if we add lactoferrin with iron, it can increase the bioavailability of iron and reduce. There are very less side effects. And so we can say that it can help in inflammatory suppression, decreasing oxidative stress, prophylaxis. It can be used for prophylaxis of preterm labor and natural immunomodulatory activity. And other, apart from lactoferrin, if we can supplement our iron tablets with B6, B12, and folic acid. I'm not going into details. We all know what are their roles. And DHA, again, we all know what is their role in fetal brain development, neurodevelopment, reduced risk of preterm labor. And with vitamin D3, again, it has a role in preeclampsia prevention and gestational diabetes. And iodine supplementation, few words. The WHO has said that iodine supplementation should be increased in pregnancy up to 250 microgram per day. Not for all population, normal population, which takes the iron-rich salt, adopted by Government of India, but the vulnerable population, their iodine content is not good. So it can affect the brain development of the fetus as result in poor perinatal outcomes. So supplementing iron along with the iodine along with iron tablet is a good idea. So I can say that's adding lactoferrin is a promising alternative. It can have a synergistic action, and it represents a hope for effective treatment in those struggling with iron deficiency anemia. And supplementing bovine lactoferrin is approved by US FDA and European Food Safety Authority, and marked lactoferrin as generally recognized safe for the use of dietary supplement. So I can say adding lactoferrin can enhance the iron absorption, reduce side effect. It has a synergistic action. It can have an immune support, and it can help in optimum iron delivery. So they offer a balanced approach to treating iron deficiency while promoting overall gut health. Thank you so much. We will discuss iron deficiency anemia in details in some other. Thank you so much.
Thank you, ma'am, for such a wonderful talk. I request Dr. Suman Gupta, ma'am, to give concluding remarks for the talk.
Good evening, everyone, and regards to my teacher, Dr. Varma and Dr. Ranjana Khanna. And thank you, Amita, for this such a boring topic in a very short time and very expertly you have explained about anemia and its management, especially the newer one, lactoferritin. I think patients will be benefited by this. But before that, we should give iron therapy in each and every girl of every age group so that we can prevent anemia before conception. And thank you to everyone. And I think Dr. Varma should conclude in last.
I think, what should I say? Amita, जो कहते हैं ना, गागर में सागर भरने वाली बात है, इतनी देर में पूरा अनीमिया पढ़ा दिया।
मैंने कहा था 5 मिनट में खत्म करूंगी।
क्या बात है, क्या बात है।
Very well
Very
done.
rightly said, very right. बहुत अच्छे से you have explained everything so nicely. The only thing is that I think you have already said that the new concept that is coming up is to give the iron alternate day or bi-weekly.
Yes, ma'am. Yes, ma'am. Alternate
So
day.
that's one thing that we can think of. And Suman has added very nice point that we should start treating anemias even when the girls when they are young enough so that they can have a build up.
Starting with adolescence.
Yeah,
Yes.
it has to start it from there so that they have a store that is full of, because there are chances that store may be full yet they may be anemic. Store may be half full, and there are 3 categories. I won't go into the details of that. So they start the pregnancy with enough storage of iron.
Actually,
so,
it
thank
should
you
start,
everyone.
But ma'am, actually it should start from birth by delayed cord clamping. We should start from that time. So delayed cord clamping will give more blood and prevent anemia in the newborn.
In the newborn. Yeah, that is how the concept is came. So that the babies which are not born are not anemic.
Hanji.
And one more thing, we should deworm each and every person who comes to our clinic.
Even in pregnancy.
Before and after.
And
second
especially when a person is anemic, one should deworm.
After second trimester.
Yes.
Not in the first.
So, Dr. Uma is there?
Yeah, I am here.
Yeah, Uma is there.
Uma कैसे जाएगी? Uma बोल.
Good evening.
Conclude karo.
All faculty on board.
Thank you, Dr. Tripathi was staying right till the end of the program.
Only 3 questions are there. How much?
I have answered all my questions.
मैम एक बच्चा था twin pregnancy वाला बताया मैम आपने?
I have already answered. I have answered all the questions. They were all for me only. I answered them all.
Yeah. Thank you, ISOPARB Prayagraj, Allahabad and Kanpur Obstetrics and Gynae Society, ISOPARB Burla, Sambalpur chapter, with academic partner Jagsonpal Pharma, or Scientific Sangam 37, granted 3 thank you FOGSI for granting us 3 ICOG point. And thank you the organizing chairperson Dr. Ranjana Khanna ma'am, organizing secretary Dr. Amita Tripathi on a very important topic, managing NCD diseases. Thank you and regards of today's chief guest, teacher of the teacher, Dr. Meera Agnihotri ma'am, for joining and showering your blessings and love on us. Thank you and regards to our experts of today, Professor Manju Varma ma'am. Always with latest knowledge and update. We have learned so much.
अपने लोगों को thank you नहीं
दिया जाता है ma'am. And your expert comment. Thank you, chairpersons. Yeah, Dr. Kanchan Sharma, Dr. Reshma Nigam, Dr. P.L. Tripathi. He is still and he is very good teacher. Very good expert comment he has made. Dr. Chitra Pandey, Dr. Leena Baru, Dr. Shali Agrawal, Dr. Suman Gupta, and Dr. Abhilasha Kumar. Thank you very much. Our learned speaker, all the learned speakers, very lucid talk. First of all, Dr. Ranjana Khanna ma'am, crisp and clear, still clear talk. Dr. Jasmine, very elaborate, very informative talk. Dr. Kiran Pandey ma'am, as usual, very important topic for today's. Dr. Kiran Pandey ma'am, and Dr. Amita Tripathi, only 5 minutes she has taken, only 5 minutes, and whole anemia she has covered. Thank you so much. Thank you, Shobhandi has not joined, but her blessing is always with us. Thank you, my dear friend and co-convener, Dr. Parul Khanna, convener, Dr. Amita Tripathi. Thank you, Jagsonpal Pharma and Dr. Deepika, for providing us this platform. Thank you so much. Thank you so much, Sanna Khanna ma'am.
Thanks to
Bye.
everyone.
Thank you, ma'am.
Ma'am, before we end, thanks
Ah,
from
I-
Jaiswal also. And we would like to just highlight, we have just recently launched FE protein, that is iron rich, lactoferrin 50 mg with ferrous bisglycinate, vitamin B6, folic acid, vitamin B12, and veg DHA plus veg vitamin D3 with iodine. This tablet has been launched recently and is available everywhere. FE protein unlocks iron's potential, normalizes homeostasis, helps in pregnancy care, iron deficiency anemia, anemia of inflammation, one tablet once daily. Apart from that, our well-known Doxipal DRL, you are all giving us support. Continue to support Doxipal DRL and the Endorect Dynogest 2 mg tablets. Thank you very much. And also a brief thing about our CSR initiative, that is My Sakhi. Do visit mysakhi.in and get to know more.